My guest today is Dr. Eric Williams. Dr. Williams is a plastic surgeon who is focused on peripheral nerve surgery, and he is a colleague and friend and has done a lot of work in the area of tibial nerve entrapments, particularly proximal tibial nerve entrapments at the level of the soleal sling. And he has actually published several papers on this around 2009 to 2012 and some work after that. But prior to that, there wasn't much discussion. There was one paper that was back in 1981, but this was a relatively undiscovered or at least unrecognized peripheral nerve entrapment. And thanks to Dr. Williams, we now all recognize it and more people are being helped because of it. So please enjoy this very fascinating conversation that I have with Dr. Eric Williams.
Welcome to the Pod of Inquiry. Ready for some thought-provoking cerebral whipping and the destruction of ridiculous medical dogma? Want to shift those stale, moldy old paradigms? Well then, don that thinking cap of yours, get down in the cave, and join our host, Dr. Stephen Barrett, for this week's episode. Let's start spelunking.
Well, my guest today is Dr. Eric Williams. I'm really excited to have him back. A few episodes ago, he and Dr. Dellin presented a great and a very successful story on nerve decompression in a CRPS pediatric patient. And today I want to talk about soleal sling. Dr. Williams, thanks for coming back. I really appreciate you taking the time.
Yeah, it's my pleasure. Thank you for having me. I appreciate that very much.
So, soleal sling. Correct me if I'm wrong, and I'm wrong a lot. So older I get, the more wrong I get. But it seems like this might be one of the newer discoveries of nerve entrapment syndromes in the lower extremity. Do you think that's accurate?
Probably would use the term more recent recognized because this was discovered and described in the past. We didn't invent this. Weren't the first people to write about it. But certainly it seems like the first that I remember hearing about it, and certainly rediscovering it for intensive purposes. And it's something that I think was largely ignored and never just looked for. So no one would really look it up. And it really came out the way we just sort of fell upon this soleal sling issue was really a combination of need and epiphany and luck. So all three of them sort of family relationships or family friends, and all three of these things sort of came together to drive us to start to consider this area of the tibial nerve behind the calf more. I mean, I don't know why. I wish I could understand why this was never an area of interest or not a heavy area of interest. It may have been our biases from our mentors, of course, who didn't see the need for this very often or didn't recognize the need, because we spend hours talking about the common peroneal nerve of the fibular head,
Right.
The main branch off the sciatic nerve of the knee, which is classically injured, and even that we spend so much time discussing it, and some of our colleagues don't really recognize that that's a problem. But the proximal tibial nerve was even more so because it just hasn't been written up as much and it hasn't been described as well. And it's half of the sciatic nerve. So, right. So I think it's one of the newer areas that we've been looking into, certainly me personally. And they're really, everything else, tarsal tunnel syndrome, interdigital nerve compression or Morton's neuroma, superficial peroneal nerve, deep peroneal nerve, common peroneal nerve, even piriformis syndrome has been around for quite a long time. That's a sciatic nerve compression upstream. So, and we talked about those all in my fellowship, and most peripheral nerve surgeons obviously should know about all of those nerve compressions. And it was really this vacuum of space in my practice that led to looking at the soleal sling. It was also the same vacuum, I don't want to get off subject too much, that made me look at the medial plantar nerve and the arch of the foot. as a, and we'll get to that in a second, later on, how we even mentioned and thought of the proximal tibial nerve. But essentially, when you have patients that don't respond to what you've been told is the best thing to do for them, after a while, you get tired of that and you start to think, well, is it something I'm doing wrong? Is it something that's wrong with the patient? Is there something wrong with the technique? Or is there another problem that we're missing?
Right.
And that's when you start to ask questions, or at least hopefully a good physician will start to ask questions. How can we do better?
So let me interrupt you a little bit, because I want to go back, because you were the first one actually that I read back in, I think, 2009, where you started talking about this, and I believe you and Lee and Gedge Rawson and there was one other author. You went into the lab, the cadaver lab, and then you published another paper very quickly after that. But if you go back into the literature, there is, I think, in 1981, a paper that I'm blanking on the author's name. But anyhow, other than that, there's not a whole lot in the literature. There's a lot of people that are talking about popliteal entrapments, Baker cysts, and whatnot. But really, in modern times, you guys were the ones to really bring this back into recognition. Although you don't want to claim to be the pioneer who discovered it, but you are the pioneer who has put it on the map where people are now talking about it. Because when we started in peripheral nerve in early 2000, nobody mentioned this. And so I think you deserve a little bit more credit than what you led on there at the beginning, because your work has changed the perception. And when you change the perception and give people ability to recognize things, then they can see it clinically, right? The eyes can't see what the mind doesn't know. So I got to give you, some kudos for that, because, had you not done that, we probably would have been stumbling around a lot longer but you're right. So that leads me to my question. There's an analogous situation up in the upper extremity with carpal tunnel and proximal median nerve entrapment. What kind of made you recognize this? What was the epiphany? That's what I want to know.
Yeah, it's kind of embarrassing, but every hand surgeon, I first of all, I'm a plastic surgeon, trained at general surgery, then plastic surgery, and then I did a year fellowship with Lee Dellin, who's a hand surgeon, plastic surgeon, and a peripheral nerve guru. And everyone who does plastic surgery and hand surgery at least has some exposure to carpal tunnel, of course, and then proximal median nerve in your forearm. And we're taught as plastic surgeons, like most of us are taught, that if you don't get better with carpal tunnel, then you need to look upstream to see if there's anything else compressing. You look at your spinal cord and you look at the proximal median nerve, because it's the same exact nerve. It's just that 10 inches, 12 inches away. It does have different symptoms, but they overlap. So the symptoms are kind of like this, okay? You have the numbness, tingling in your hand, usually. Sometimes you have more muscle weakness in that. But we all know that, or at least you should know, that if they don't improve with carpal tunnel, if you care, you're going to try to look for other nerve compressions. And then I was literally looking at, I think it's Grant's Anatomy, maybe Gray's. It's either Gray's, Grant's, or it doesn't matter which book you look into. But this particular drawing of the forearm in the next chapter over, which is the lower extremity, if you look at the back of the calf with the gastrocnemius removed, it looks almost identical to the forearm. You're like, it's a bunch of muscles, there's nerves and blood vessels, and there's a, wrist, and the ankle's cut off because it looks like it's a wrist or an ankle. And I was just sitting there thinking to myself, that looks exactly like the proximal median nerve. I can get the drawing if you want me to. If you want to put a pause on this or something, I'll grab my drawing. I'll just show you the picture. Yeah. And I'm like, you couldn't draw a better nerve compression. I mean, the nerve travels through this arch like this, and it literally is a noose, literally. And, the only issue with that was like, why doesn't everyone have this problem? And then I combined this with our friend in the Association of Extremity Nerve Surgeons. He's a hand surgeon. and I'm blanking on his name right now.
Probably Jay Erickson.
Jay Erickson, thank you so much.
Right,
Jay
right,
Erickson was very, very, very passionate about the proximal median nerve.
right,
And I was like, this is the exact same problem. And this is one of those problems where Dr. Erickson has a strong belief and fairly good proof that every single person has the compression
right.
of the median nerve, and he can show you, and he does at the meetings. He's like,
Yeah,
"Oh, I'll show you." I'm like, "Well, I don't have any symptoms." No, no, you do, but I don't. But and so
right.
I started thinking, this is the exact same issue. No one walks around complaining about it except when you complain about it. And so that was one little thing, was is literally the picture in the textbook of every anatomy textbook in the world that looks at the tibial nerve coming through the soleal sling. So that was number one. Number two was the corollary with the hand and the leg. They're not perfect mirror images, obviously, but there's a lot of correlation between the two. And then it was the fact that I had patients who did not get better from tarsal tunnel that I was frustrated with, and I didn't have an explanation for it. And then the thing that just flipped everything and flipped the switch from that's an interesting observation to aha, this is the problem, is I had a family friend, have a family friend, he's still very much alive. He's a mature statesman. He is a vascular surgeon. He was at University of Virginia, Dr. Don Detmer. And he specialized in chronic exertional compartment syndrome. And but he was a pioneer in that, because as most physicians treat compartment syndrome, it's usually after a crush injury, or usually after we see this in soldiers, young men and women who are forced to march 50 miles a day when they haven't done anything but stay on a couch for a long time, and their muscles grow very quickly, and they get what's called exertional compartment syndrome.
Right.
Or we see this in runners, we see this in athletes who are training very, very hard, and we don't know what causes it, except perhaps maybe the muscles grow so quickly, and then the compartment around the muscle doesn't grow. And so you create incredible pressure inside the compartment. And what happens is you exercise, and at minute number X, whatever, it's usually very consistent. 5 minutes later, they have terrible pain in their leg. And it gets to the point that if they keep going, they literally can't move because their foot goes numb, and it gets paralyzed because the muscles get weaker and weaker and weaker. And then they stop. And then some period of time later, it gets better. A couple hours or a couple minutes, it gets better. And they walk again or run again, and within the same half a mile, their leg is numb again, and they can't walk, and the pain is incredible, and it goes on and on and on. And they get treated for a long time for stress fractures and all sorts of other different things, until someone measures their compartment pressure, and it's off through the roof.
Right.
But most of plastic surgery, most of orthopedic surgery, most of podiatry, lower extremity salvage people are familiar with acute compartment syndrome. The acute compartment syndrome, at least as I recall in my training, we were trained to release the compartments basically in the mid portion of the leg. And I do have a drawing. I hope this shows up. I'll try to hold it very, very still for us. But where we're talking about the soleal sling, we're talking about this area right here behind the knee, because it looks like a sling. It looks like a noose going around the vessels and the nerve.
Right.
And when we used to release these compartments for acute trauma, we released the compartments here. And I don't recall ever releasing the compartment all the way up in this location here, at least as a resident. It's been so long since that. But certainly when you now switch over to how do you treat exertional compartment syndrome, it appears that the majority of the people in the world have been treating that by releasing that same center of fascia in the mid-lower leg. And where Dr. Don Detmer came in was he made his name and really made a living trying to re-educate people, trying to get better outcomes, because those patients don't have great outcomes.
Right.
And well, we tried, we released their compartments. They're all, they should be all better now.
Right.
But realizing they weren't getting better, and so he began releasing the compartment where basically it's like the inlet or the outlet, depending on which direction you're coming. It's
Right.
the compartment inlet or outlet. It's kind of like thoracic outlet syndrome in the neck. Is it an
Right.
inlet or is it an outlet? The answer is yes. It's the blood comes in and it can't get out. So exertional compartment syndrome, blood comes into the compartment, but because the muscle gets swollen, it then pinches a low pressure system,
Right.
i.e., the vein. The
Right.
vein is low pressure. We have 120 to 190, millimeters of mercury going into the artery, depending on what your blood pressure is, and only 12 to 15 millimeters of mercury on the way out. So which is going to be pinched first? The robust artery that's pulsing at 160 millimeters of mercury, or the vein that's just passively flowing blood at 12 millimeters of mercury? And the answer is the vein. The vein gets pinched.
Right.
So blood comes in and blood cannot get out. And so now you have this engorgement, which is why patients who have exertional compartment syndrome have to stop walking,
Right.
because they get so engorged with blood that they literally can't function. They lose sensation. The pressure builds up and up and up, and that compartment rises. So Don Detmer was releasing and started releasing the sling, where you then now open the gate, the vein goes boosh, and all the blood rushes out.
Hmm.
And now all the blood you want can come in and all the blood you want can go out because there's nothing impeding the blood exiting the leg. But it is truly amazing in 2025 that we still are releasing most exertional compartment patients in the middle of the leg. At least those
Right.
are the ones that I see. Now, there may be millions that are not done that way, but the ones that come to our office that occasionally make it to us, they really have never, when I go in and operate on those patients, it's a virgin territory in the back of the calf. And
Right.
part of the reason maybe because people don't want to get near a big blood vessel, which is of course,
Uh,
reasonable, but
I would
what's our
say
expectation?
I would say part of the reason is because they just don't know about it.
That's absolutely true as
It's
well.
not classically taught. And
Yeah.
that's why your work is so important, is that and so let's go back a little bit to what you touched on with Jay Erickson. And he has his muscle maneuver where almost everybody, I mean, he's done that on me. And it's like, wow, I didn't know that. I didn't, so we're all walking around with these subclinical nerve entrapments, so to speak. But it's very easy to test the muscle function of the EHL, extensor hallucis longus, for common perineal or common fibular nerve entrapment. And is there a muscle that you go to for evaluation with the proximal tibial at the soleal sling?
Yes. So Dr. Detmer, when he happens to be a family friend of ours, and so I know him well. And so when I started working in peripheral nerve, he was very excited. He's retired now. Very excited to share his passion for exertional compartment syndrome and for at that time what we were just calling exertional compartment syndrome. And there are two exam findings that are really I think the most reliable. I can't say they're infallible, of course, but they are certainly the most reliable and the most obvious findings that you can find. One is weakness in the toe flexion. So instead of toe extension, which is the common fibular or common peroneal nerve with dorsiflexion and extension,
Right.
the tibial nerve goes to plantar flexion and flexion of the toes. And so just one of the easiest muscles to check is the flexor hallucis longus, and it's the big toe muscle flexing downward. And you
Right.
can compare the good leg to the weak leg, and the patient has no idea they have weakness until because no one checks that on themselves. I mean, we at least we
Right.
use our thumbs and we have to write, and they say, "Well, I can't hold my pencil," or things don't work well. But in your toes, in my world, no one complains about their toes unless they hurt.
Right.
And this nerve compression probably is that's not the most common thing they complain of, is pain in my big toe from this nerve. But when you check it as a clinician, It seems like it's one, the easiest muscle to check, because how do you check your pinky toe flexion? I mean, it's almost impossible. The toe is so small and no
Right.
one moved their toes that well anyway. The only problem with the great toe is if you're an older patient, or if you have a lot of arthritis in your leg, toe, or if you have a bad bunion, that can be a little bit awkward to check that. So it does become a little bit difficult. You have to make some amendments to your exam.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor.
I'm constantly exploring new avenues to enhance well-being and address any health concerns. Today, I'm thrilled to introduce you to an exciting supplement called STEM Regen, which I take daily and genuinely believe could revolutionize your health journey as well. STEM Regen stands out as a game changer in the realm of wellness. Crafted from 5 potent plant extracts, it boasts a remarkable ability to stimulate the release of your body's own stem cells from your red bone marrow. Why is this significant? Well, stem cells are the superheroes of our body's natural repair system. They possess the extraordinary capacity to morph into various cell types, aiding in tissue regeneration and repair. As we age, the quantity of circulating stem cells in our system reduces significantly, impairing our body's ability to heal and rejuvenate itself effectively. STEM Regen steps in to counter this decline by kickstarting the release of stem cells into circulation, thereby bolstering your body's innate repair mechanisms. Once unleashed into your bloodstream, these mobilized stem cells actively seek out areas of damage or injury, initiating the healing process. By incorporating STEM Regen into your daily routine, you're essentially empowering your body to tap into its own regenerative prowess more efficiently. I firmly believe that STEM Regen could be a valuable addition to your wellness regimen, especially if you're seeking to fortify overall health and vitality, accelerate tissue repair, or expedite recovery from injury or illness. This first of its kind stem cell mobilizer is changing the game in regenerative medicine. Don't wait to unleash your body's innate healing capabilities. Visit stemregen.co/Dr. Steven, that's with a PH, and use the code SBPOD to get a 15% discount off your first order of STEM Regen.
But you can still compare one side versus the other. If it's bilateral, you can at least compare it to what you have seen in other patients. And you say, no, that's pretty darn weak compared. And you try to isolate the one joint. You try to isolate just the distal joint and measure that. And you can test that pretty easily. And the other clinical sign that we use, I've kind of termed the open eyeball sign. And again, I didn't make this up. I gave this, I learned this from Dr. Detmer, so I'm giving him all the credit here. But he was, again, doing this for exertional compartment syndrome. And a close diagnosis of that is actually popliteal artery entrapment syndrome, which is an artery problem, not a vein problem. But it's very similar anatomy, similar location. And so this clinical sign is specifically for the Soleal Sling Syndrome, we'll call it. When you press behind the soleal sling, it's about what we published this paper. This is the first paper we published, was how do we examine this? Where is it located?
Right.
And it's located about, just roughly about a handbreadth below the knee. So if you put your hand in the popliteal fossa against the back of their knee, if they're sitting in front of you with their knee at 90 degrees, like most people are sitting on an exam table, you put your hand in the back of their knee against their hamstring tendons, and that soleal sling is about 9 centimeters. It's about the tip of your pinky finger. Now, if you're Shaquille O'Neal, you may be your second finger or third finger, but if you're and if you have dainty hands, it may be another finger below it. But it's about 9 centimeters is what we measured in the cadavers, and that's where the soleal sling. And you can literally push with your fingertips behind them in the middle of their calf, right in the midline, and they'll be normal, and then their eyeballs will literally pop open, and they will literally jump off the table in many times. And if they don't jump off the table or they don't pull their leg away, then I even doubt whether they have that diagnosis. And I wish I could say that we've done a, I wish I could say there's something to compare that to. Like, what else is a better exam? And the answer is, unfortunately, I have not gotten so far as to find a different exam. I've tried. I've tried looking
Have
at
you
MR neurography.
have you ever
Go ahead.
looked at like toe raises? So you put them up against the wall.
I have not, because you would think that the posterior tibialis would also be weak, because those muscles, the posterior tibialis, the extensor, the flexor digitorum longus, the flexor digitorum longus and the flexor hallucis longus, all of those muscles their nerve function comes off downstream of the soleal sling.
Right. I
But
understand that, but what we found was if you take these people and it's basically it's just an exacerbation of a provocation sign. So if you take them and you put them on their good leg and you have them, lift their symptomatic leg and then have them do 10 toe raises, they're holding themselves against the wall, and then you press right in there where you described 9 centimeters below the popliteal fossa, they'll say, yeah, I can feel that. You do it on the other side and you press in that same spot right on that soleal sling, they really open up their eyes a lot. And that was something that we kind of picked up but like you say, a lot of these people, they are they're enigmas, because they've been given some other diagnosis or they just failed their tarsal tunnel. But that's why I asked you about the provocations. Well, not only the provocation sign, but the muscle strength, because a lot of these folks, and if you look at a lot of people with other complaints and you just look at EHL function on both sides, they'll have like what Jay Erickson describes in the upper extremity. They'll have some weakness in that they never knew about. But then you start questioning them, and some of them will say, "Oh yeah, I've been tripping a little bit more than usual, or whatever." So it's kind of an interesting thing. I suspect that there's a hell of a lot more of these subclinical nerve entrapments going on than we ever thought.
Oh yeah, there's no question that is the case. And also, there's another group of patients that we think this may be very, very helpful for. And this is an interesting group that I have not delved into. I don't have the referral pattern. I could dig into it, but Don Detmer described these patients, the post-Phlebitic pain syndrome patient. This is a patient who's had a DVT, because again, this is another place. This is the exact location where DVTs occur. Mm-hmm. The deep venous thrombosis, the blood clot in the back of the vein, or actually blood clot anywhere in the venous system in the lower extremity or upper extremity, but the deeper veins, not the superficial veins that you can physically see. When these patients get a DVT in their calf, which is where the one of the most likely locations where it occurs, their leg, again, blood can't get out, so it swells tremendously and it hurts a lot. Right. Probably because there's so much pressure now on the tibial nerve, and obviously it's right there at the same location. You have inflammation around the tibial nerve at the soleal sling. And then the treatment, of course, is not to operate on those patients, but is to anticoagulate them.
Right.
But even after those patients recover with their blood clot dissolves, many of those patients, at least per Dr. Detmer, had post-Phlebitic pain syndrome. For years, they would walk and they'd exercise and they would get pain in the back of their calf. And the question is this a compartment syndrome? Is it a nerve compression? What is it? Right. And so when you release that soleal sling in that patient, if they have the same exam signs, if they have pain behind their calf with palpation, they might have weakness in toe flexion, they have an appropriate history, then if you release that fascia, many of them will see tremendous improvement in that pain in the back of the leg that occurs when they walk.
Right. Well, it's very interesting. I wanted to ask you a question about one of your first articles, I think was 2012. Was it Annals of Plastic Surgery, where you talked about the combined common perineal and tibial nerve entrapment, where you had dual entrapments going on. What's your thoughts on the prevalence of, I mean, obviously I would say there's many more common fibular nerve entrapments or common perineal nerve entrapments than proximal tibial just based on my clinical experience, but I'm not sure that that's correct because of, again, going back to perspective and being able to look for it. What's your thoughts on that?
Well, this was exciting because when we first wrote our papers, we first started with, well, let's just show where this compression could possibly be.
Right.
And then then the next thing was, well, we have a couple of patients in the practice that have pain. They have a common peroneal nerve, but their pain isn't only on the top of their foot. It doesn't go only from the top of the knee and lateral knee to the dorsum of the foot, but they have pain in the back of the calf and to the sole of the foot. But they didn't have a sciatic neuropathy. They do an EMG nerve conduction. The sciatic nerve upstream is perfectly fine. Their back is normal. And then we would examine them and they did not have tarsal tunnel syndrome. So if they don't have tarsal tunnel syndrome and they don't have sciatic nerve injury or lumbar radiculopathy, a lumbar compression, well, where is it? And then all of those patients, if I'm not mistaken, all of those patients had a lower extremity trauma of some sort. They had some injury. They may have been, bad ankle sprain or a crush injury in a car automobile accident, or they had a fractured tibial plateau fracture or a proximal tib-fib fracture, something that would put energy and possibly bruising, possible bleeding, possible inflammation in the region of the popliteal fossa. But the key was they had appropriate symptoms in the sole of the foot as well as the top of the foot.
Right.
That's the common nerve. And they didn't have downstream findings at the tarsal tunnel. And they didn't have, and so it has to be the soleal sling. And when we started looking for it, remember, you don't look for what you don't know.
Right.
And you don't know. So when we started thinking about this, we started looking for it. And these people would jump off the table when we examined them. So we would release those nerves for them at the soleal sling. And those 3 patients were dramatically better, almost instantaneously when they woke up from surgery. They knew immediately that their pain was gone because these exertional, again, is it a nerve compression or is it a vascular compression? And the answer is we don't really know. Sometimes you can get vascular studies and they're totally normal. And the patient has some symptoms of numbness and tingling. You get an MR neurography and the nerve is totally normal.
Right.
You get an EMG and the nerve is totally normal. Right. And so is it vascular? Is it pressure? Is it compartment? Or is it nerve compression? And so I think there's going to be patients that have all of those different categories. It's just a very interesting narrowing in the body that can explain a lot of different symptoms in the leg. And when I made a joke with Dr. Detmer that you think you're a blood vessel doctor, you really are just a peripheral nerve surgeon releasing all these nerves, because if the vein is pinched,
then
the nerve is got to be pinched, because the nerve is usually in front. If you do these dissections, you see the nerve is actually in front of, against the soleal sling, and then the vein is behind it, and then the artery is behind that.
Right.
So if the vein and the artery are pinched, the nerve has to be pinched. So I made a joke with him about that, but he's just a peripheral nerve surgeon, not a vascular surgeon. So but it has been a game changer for many patients.
Have you seen, so I don't know, 4 or 5 years ago in the cadaver lab, we started looking at basically the tibial nerve all the way from its bifurcation from the sciatic all the way down into the tarsal tunnel, and started noticing that in some of the specimens there was some pretty significant evidence of tightness where the tibial nerve was coming out of the deep posterior compartment into the subcutaneous space, I don't know, 12 centimeters proximal of the tarsal tunnel, in that neighborhood. And on patients, you can go and you can press on that area and they'll say, oh yeah, that's definitely not a fun area for you to press on. And so I decompressed a fair amount of those, as well as soleal slings, but it was another site of entrapment that we'd really never thought about until we started taking a look at it. And then it's funny how you start remembering these patients after you make a discovery in the cadaver lab and go, oh man, you see that patient in your mind that you couldn't quite figure out 4 years ago or 5 years ago. What's your thought on that additional site in addition to the soleal sling?
This is, I think you and I are referring, I think what you're referring to is the deep posterior distal compartment. So
Right.
we think of the compartments in the lower leg as the deep, you have the anterior and the lateral, you have the
Right.
superficial posterior, and you have the deep posterior.
Correct.
One of the things that, again, just a family friend, Dr. Detmer, and Epiphany, was that essentially he discovered there is a deep distal compartment. I think it was him. I'll give him credit. A deep distal, sorry, I gotta say it right. Deep posterior distal compartment and the deep posterior proximal compartment, and they can be completely separate. So you
Okay.
can release the compartment, the soleal sling, and it does not release the compartment at the lower ankle. And that is why when I do tarsal tunnel releases, I've had a number of failures early on where we would release it, at 5 centimeters above the medial malleolus or something of that nature, just as
Right.
far as we get a little retractor, look up there and divide the fascia.
Right.
But I've switched to using my finger, putting my finger along the tibial nerve and vessels and making sure I can get my finger in there.
Right.
Because some patients, especially these really, really rigid, tight, you know what I'm talking about, the people
Yep.
who are so muscular, it's like that you can't even push on their legs. They're like pipes.
Right.
They're like they're built like a machine. And it's usually the diabetics, well-controlled diabetics. They're just tense. Everything about them is tense. The fascia is tight, the skin is tight, and they're about to burst,
Right.
They don't even have to be obese. They're just muscular, thick folks. I put my finger up and I couldn't get my finger along the tibial nerve and the vessels. So I'd have to extend my incision a little bit, get a longer retractor, get a headlight up there with a long blunt tip scissor, and release that up another 6 centimeters or so until you can literally throw your finger up there without any problems. You gotta be careful of bleeding, of course, but
Right.
and I believe what you're talking about, we release on every single patient, is called the very end of the deep posterior distal compartment.
Right.
And they would
Almost at the junction of the medial gastroc soleus. In that, right.
Yes.
Yeah.
Yes. And so that may be a little higher up than the one I'm referring to, though, actually, now that you mention it. It's more, what I'm thinking of it is basically right at the end of the soleus muscle, above the ankle. It's a good 4 to 6 centimeters above the lateral medial malleolus.
Right.
So you may be at a different, if you're that high, you may be.
I think we're higher up. But
Okay.
I've seen a lot of what you're talking about, and that's something that we always checked. And it just, but my point is that when you're examining these people, you have to be cognizant that these nerves can be entrapped at different levels. And
Absolutely.
So, it's just another point of awareness, I believe.
I think physical exam is key. If someone has symptoms in a body part, sole of the foot, and you think you know what it is, and their exam doesn't match, you have to follow that whole tibial nerve. And usually that patient's going to tell you where the entrapment is, usually, because they're going to jump off the table frequently. And that's how we make these discoveries, because you can have an anomalous muscle, you can have a fascial band that
Right.
is very rare. And those can be hard to discover. And I'm sure I've missed some, in the past where I just scratched my head, I couldn't figure it out. But there are going to be areas of entrapment, and if you follow that tibial nerve up, you may find specific areas that are tighter than others. But the two that we talk about the most are the tarsal tunnel and that soleal sling. And
Right.
I would be very interested in seeing that other, the deep distal posterior compartment is a compression point for sure.
Yeah, it's something that I never really thought about until we were talking about it in the cadaver lab one day, and then we started, dissecting it out. And we wanted to see, are there other areas? And then once you start looking at things in the cadaver lab, then you can take that into your clinical practice and kind of marry that knowledge together. And it's all of a sudden it's like, oh man, maybe this is another reason. Maybe they don't have a soleal sling entrapment, but they have this more proximal distal. I mean, you start getting into too many proximals and distals and in this, nomenclature and everything. But, so I guess it's one of those things where, the anatomy books help you a lot, but they don't recognize everything that really is going on in human peripheral nerve situations. So let me get to a question that I always get asked anytime we're teaching a course, and that is, what is your standard approach to a soleal sling decompression? Medial, lateral, posterior? And give me your thoughts on that, because I think there's a lot of discussion in this part of the topic.
I almost always prefer a medial approach. Going medial, it is very straightforward for the most part. It is in an area that heals very well. I believe someone had written something from a lateral approach, but I have not looked into that at all. I've never done that. I also am familiar with, and you need to be facile with, the posterior approach. And some of our colleagues have written about that. And I hate that approach personally. To me, and the reason is this, there are more things that can go wrong from a posterior approach. We have, first of all, the different things when you go into the leg from posterior to anterior. You got the sural nerve, which is right in your face.
Right.
And you have to put a retractor next to that somewhere. And you have a very long area that you're going to potentially injure that nerve. And that's a problem. Injuring the saphenous, the sural nerve, I'm sorry, is a problem. And I've seen it numerous times. I had a patient who flew from California to see me because of that injury. They just, I assume they put a retractor on it, though we don't know exactly what happened. But the nerve was clearly a neuroma in that area. And then once you get through the two heads of the gastroc, now you're looking at, you got the motor branches coming to each head of the gastrocnemius. You have the motor branch that goes to the soleus muscle itself. And you really you have actually more visibility of the vessels themselves, the actual popliteal vessels, which you don't really want to pop into one of those when you're in a surgical center. That's a really bad day.
And now a message from our sponsor.
I've been taking Nature's Marvels bioregulatory peptides for more than 3 years now on a very consistent basis. It's an integral part into my wellness journey, and I can't imagine not even going on this journey without that. These are designed with cutting-edge science to optimize and restore your body's natural processes. After 3 years, I can say without a doubt, this isn't another wellness product that just gets pushed to the back of the cabinet. This is the real deal for human optimization and longevity. Start your journey today with Nature's Marvels. Our website's below.
For the patient and you. And so, but there are going to be patients who have some catastrophic complications in the back of their knee. And you're going to need to get to the common perineal nerve and the sural nerve and the popliteal fossa, and the proximal tibial nerve. And it's a perfect approach. It's great. It's fantastic. And so you can do that. Now, there may be other people who have done it through smaller incisions posteriorly, and they may do more minimally invasive and come down, and you're still going to be in a deeper hole with less exposure, in my opinion. That's an opinion, strong opinion. The medial approach, going in from the outside in, going from the inside downward, you got to take care of the saphenous nerve. You got to be careful of the saphenous nerve. So that's sural nerve on the back, saphenous nerve on the medial. And then essentially what you're doing is you have full access to the plantaris tendon, which does sometimes wrap around that. And so I've been taking that out recently. I don't have great evidence that you have to do that. I don't have like 3 patients that failed because of it, but the vascular surgeons and Dr. Detmer would remove that for popliteal artery entrapment syndrome, because it does, and it can wrap around the artery. And there have been times when I've been completely convinced that the plantaris tendon and muscle wrap around the nerve. So I do remove that. And it's hard to do that from posterior, but you can. I've done it, and every time I've operated posteriorly, I do that because I look for the muscle and I take it out. But then you're basically looking right at the soleus muscle, and depending on where you are on the soleus, you may come from the soleal sling downward with a very blunt clamp, and you can work downward, or you can just peel the soleus muscle off the deep fascia. You just literally peel it from medial to lateral, and then you just very gently dissect through that fascia, and then you carefully release it, looking for the blood vessels in the nerve with a blunt tip scissor, blunt tip.
Right.
And then you can kind of reach up and release it until the soleal sling is released, and you can reflect it backwards, or reflect the muscle laterally. So it's a pretty safe approach. You almost don't even see the veins, the big popliteal vein, until you actually release the soleal sling. But you have to be very, very careful either way, posterior or medial.
Right.
I prefer medial every day of the week, but if I have a complicated case that needs common peroneal and proximal tibial, then I will sometimes choose it, especially in redo surgery, if they've had major operations. If I'm removing the sural nerves at the same time for any reason, if they had a big trauma injury to the leg, then sometimes I'll do that, because now you have full exposure to the medial and lateral sural nerve, and even the occasional lateral cutaneous nerve to the calf that lives back there. And also, who wants to put a person in a prone position? I mean, it's riskier anesthesia.
Right.
Yeah. It takes 30 extra minutes. You got to roll them on their stomach. You got to put a breathing tube in instead of putting an LMA in there and put them on their back. Who wants to go on the stomach? Nobody. So it's a way easier approach, in my opinion. But you should learn how to do it in both directions, from posterior as well as medial.
Now, I think what you were referring to, the lateral approach, Dr. Ellison out in Surprise, Arizona, he's got a fair amount of cases. I think he's got we're actually working with Midwestern University now to do a retrospective study on his work, because he's found that in cases that have both soleal sling entrapment as well as tarsal tunnel, he would do the common fibular release, and from that same incision, swing it down a little bit more inferiorly. And then, believe it or not, the soleal sling is not that far from the common fibular nerve. I mean, it's maybe 2 centimeters at that. And I've seen him do it. And I've done them in the lab, cadaver lab, but I'm much more comfortable with the medial approach. But in his hands, he's done very, very well. And what's interesting, and what we want to look at his data, is that he never primarily does the tarsal tunnel. And so he's only doing the proximal compression. And what's real interesting, I think, and I don't have the statistics yet, we're still looking at the data, but it's a small subset that have to have an additional tarsal tunnel decompression. So if you have this double crush, a lot of times, as you know, if you take care of one, it gives you enough that the other can be overcome by the patient. So it's kind of an interesting thing.
It is interesting. And this is a conversation I have with every single patient that we have. Do you have proximal and distal? And this was going back to the podcast you just did. It depends. If I believe someone has both, I often ask the patient to help us make a decision, because the patient knows as much as we do, if not more, because it's their leg. And they have, I don't want to try to guess what kind of a patient they are. What's their personality? Are they aggressive? Are they passive? Are they scared? Are they, injured by another physician? How do we treat the human being as a patient, not treat, and that's very important to me anyway. I hope it's important to most people, about how do you treat the human being in this while trying to be a scientist / surgeon / caregiver, and knowing that you're not always right. And how do you manage risks and benefits? And so the fact that we can get a double crush, I've also seen many patients who don't get better. And where you have, again, we use the Godzilla terminology, standing on your garden hose. If you can think of, you got a big old, Godzilla standing up here on the garden hose, and maybe you don't know what you may have. How much
pressure is distal?
Yeah, you have another one standing down here. Which one's bigger? Which one's bigger? And the answer is sometimes we don't know. If they had trauma to their ankle, you might start with the tarsal tunnel and come back later with the proximal tibial nerve. If they had trauma to the knee, you might go with the proximal tibial and then the ankle. If they had trauma to their leg, then you may do them both, or you may do them both anyway in any one of those situations. But I always ask the patient, because if they're traveling long distances, then it can be very difficult for them to get back to you to see you. If they're right next door in the backyard, then they may not care. If
Right.
there's so many different things that occur. I always ask the patient to help make that decision if I think they have both. Many people will choose to do them both, and I tell them very clearly, and I think all surgeons should, we don't know if you need both,
Right.
but you have symptoms of both, and therefore it's not unreasonable to do them. And if you want to be cautious, you do one and come back. If you want to be aggressive because you've been at this for 10 years now and you're about to chop your leg off, you actually might do them both at the
Right.
same time.
Well,
So,
I think you make an excellent point, and this is something that we try to convey to our nerve fellows is that these people are individuals, and you can't fit them nice and tidy into an algorithm because they all have all of these different nuances going on. And so I think it's really important what you say is that you have to really look at them as an individual, what context they're in, what's their work, what do they want to, achieve in the future, all of these things. And so anybody who says peripheral nerve surgery is easy is either a tremendous liar or clueless, in my opinion. I mean, because the actual procedures themselves may not be that difficult to do, but where the secret sauce comes in is deciding what to do.
yeah, I agree. I mean, if you're doing mainly nerve decompressions, I joke to my staff in the ORs, like, yeah, I'm a half a vascular surgeon now. Here I'm going to expose the artery that the vascular surgeon would then come in and do their fem-pop bypass. That's the operation. They're doing the fem-pop bypass. We're just doing
Right.
the exposure to it.
Right.
And but there is more than just the procedure. Some of the peripheral nerve procedures, of course, are extremely complicated when you start talking about nerve transfers and making sure you're
Sure.
transferring the right nerve and things. So
Right.
there are opportunities to screw up everything, for sure. But really, I think a lot of the satisfaction from what we do is treating the human being. And that's where I think the art of medicine comes in. It's not algorithmic.
Right.
It is to a certain extent, Look up, look down, look to the
Right.
side, check for other nerves. Okay, we did that. Address what you can. And we have those ideas and rules to follow, but every human being in front of you is different.
Right.
And they may not tolerate that.
Right.
Or maybe they need to do that and they need to suck it up and have 4 incisions instead of 1. So it's just a challenge that every day is different. Every patient is different. And if you go into it thinking that you're going to treat everyone the same, you probably won't have a lot of patients in a while because
Right.
there's going to be either too many complications or patients are going to feel that you're just nickeling and diming them. You're just trying to get the biggest bang for your buck or whatever. That is something's going to come out if you just start to treat people just like a boom 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 boom, and you need to talk to them and get their opinions on what they want. Not that
Right.
patients should dictate everything that you do, of course, but I
Yeah,
think
but I think
my point
I think you're
is
making a point too. When you talk to the patient, you're assessing their psychology. All right. And it's it's very apparent sometimes just when you work patients up that they have unbelievably unrealistic expectations. And no matter how precise you are and how precise you are in the surgery that you perform, the likelihood of getting that person better versus the guy who's like, yeah, if you could get me 20, 30% better, I'd be totally happy. I mean, there's a lot of delicate stuff going on in the brain after a peripheral nerve gets hurt
yeah,
or entrapped. So it's more than just a routine mechanical exercise,
for sure.
in my opinion. Eric, so man, I could get into this tibial nerve. It's something that I think is fascinating. I think there's still a lot that's not known about, what's going on. I mean, what the peripheral biomechanics are doing to this nerve, doing these compartments, all kinds of different things. But it's been a fascinating discussion. And hopefully we can come back and revisit more. I want to thank you personally for your work because it's helped me and many other of the surgeons in ANS. So thank you for that. And look forward to seeing you at the nerve meeting. But before we go, tell everybody how they can find you and refer people to you, because you are a very rare guy that's doing what you're doing.
I appreciate that. Yes, we're in Baltimore and Towson, Maryland. We have a website, drericwilliams.com. That's drericwilliams.com is the easiest way to find us. We still are the Dellin Institute for Peripheral Nerve Surgery in Baltimore. We haven't changed the name of that practice. He's the one that created it, and I took over when he retired. But the website my website is drericwilliams.com, and we'll be happy to evaluate. We have an intake system that our staff goes through, and we try our best to get through that as quickly as possible to do that. But I will say one last thing, and you can choose not to put this in the system. I will say that when we think about patients who failed tarsal tunnel, this is real important because I just did 2 revision tarsal tunnels this week. We look for proximal tibial nerve in those patients.
Right.
And if you were the appropriately trained surgeon, I'll put quotations around that because we have a little bit different training. Obviously, you as well, everyone in the Association of Extremity Nerve Surgeons presumably have a different background on how to do a tarsal tunnel release. But this week I did 2. One was very straightforward because the physician did not release the medial lateral plantar tunnel.
Right.
They just didn't release it, period.
Right.
And so you look still for downstream problems. I just want to say that over and over again. Now, in both those patients that I operated, I did do the proximal tibial nerve as well because they were exquisitely painful. And I gave each one of those patients the opportunity. Do you want to come back and do this, or do you want to do this one first? And we had that very specific discussion. But I will say if you're not the trained physician, if it's not your tarsal tunnel, if it's not Dr. Barrett's tarsal tunnel that failed, then you still have to think very strongly about, do I need to take the risk of doing a revision tarsal tunnel? And you may say that's just too risky. I'll do the proximal tibial nerve first. And if that makes you 50% better, you may be perfectly happy and you don't need anything else done. Let's not take the risk of going back to a previously operated field. So I encourage physicians to really think hard about that can I look for the proximal tibial nerve? I'll say that this paper, the 3rd paper that we published, was on a series of failed tarsal tunnels. And when we did the proximal tibial nerve in those patients, all of them, overall, we had a 50% success rate. Now, some people looked at us and said, that's terrible. I said, well, yeah, I guess it's terrible, except that that's 50% of them were cured and they were ignored previously without any relief at all. Exactly. So we thought we were hot snot that we made 50% better. Okay. So it is what, we were excited. I want 100%. But when you look at those trauma patients, the patients who had some kind of a trauma, some blow to the leg, some injury to the leg, like 92% of those patients were cured. Mm-hmm. Whereas you look at the sort of the diabetic, potential well-controlled diabetic peripheral neuropathy patients who have tarsal tunnel syndrome, only probably 30% of those or so got relief after I did after a failed tarsal tunnel. About 30% got better roughly after that proximal tibial nerve. So if you're a surgeon, you're going to go out and try to do this. My point of that is work on the patients who were injured first. Right. And build up some really good outcomes in your own mind and convince that this thing actually works before you start expanding it to other people.
I got to comment on that because one of my colleagues and good friends over in Madrid, their group has just done, and this should be submitted for publication soon, but they did a significant amount of cases. I think it was 50 cases of tarsal tunnel where they measured EMGs before and after 3 months post-surgery. And all 50 of them, and that is an arbitrary number. I don't know if it was 50, but it was in that neighborhood, okay? So all of them, 100% of their patients got an improvement on electrodiagnostic testing. If not completely normal, post-operatively radically improved. But like 30% had continued pain. So what is that saying? That's just saying that these guys are doing a great job. They're not hurting the nerve. They're doing what they need to do to improve nerve function, but that doesn't always correlate to relief of pain. So there's some centralization going on. So I'm anxious to see that paper published, because I know a lot of surgeons who agonize, and I know, I mean, I never think about the 98 out of 100 that got great results. I dwell on the 2 that didn't. That's just our nature, right? I mean, but the fact that they were able to show that normal electrodiagnostic studies at 3 months post-op doesn't necessarily mean that there's a complete amelioration of pain. And so, again, it goes back to what I'm saying. This peripheral nerve surgery is not an easy game to be in. It's a damn hard game. And, and sometimes you're just going to get beat up.
Yeah, for sure. There are some weeks that are better than others, no question.
Yep, absolutely.
I wish I could say they were all fantastic, but they are not all fantastic.
Nope. Eric, thanks so much, man. I love what you're doing, and keep doing it.
Thank you so much. I appreciate your time. Thank you very much for including me. I appreciate it.
Well, folks, if you are over 40 and you are not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to the health of so many bodily functions, not the least of which is cardioprotection. If you have any question on nitric oxide, I suggest that you register with Approved Medical Solutions and begin receiving their educational emails. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, Approved Medical Solutions created the only nitric oxide replenishment formula without oxalates. Approved Medical Solutions does not use beet, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett at checkout, and you'll receive a 10% medical discount savings. You can register to receive educational emails without any purchase. For licensed practitioners, you too can go to approvedmedicalsolutions.com and get registered today. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see every one of them be deficient. When they see this result, they will want you to start them up immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates. I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, podofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex, please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.